Good afternoon, everyone. My name is Alaina Murphy, and I'm from the Kentucky Injury Prevention and Research Center. Today, I'll be presenting on injuries and access-related risk factors among Kentucky residents age 60 and older from 2018 to 2024. This presentation looks at injury patterns across emergency department visits, hospitalizations, and deaths with the goal of understanding who is most affected and where we have opportunities for prevention. Here I have listed the data sources I used to put together this presentation. I use our death data, our emergency department discharge data, and our inpatient hospitalization discharge data. To start, here is a brief overview of what we'll cover today. First, I'll provide some background on Kentucky's aging population. Then we'll move into injury trends. After that, we'll take a deeper look at falls, which is the leading cause of injury in older adults. Then we'll expand into other injury types, including motor vehicle injuries and poisonings. And finally, we'll discuss mental and behavioral health, including suicide and self-harm, and then wrap up with some key takeaways. Kentucky's older adult population is rapidly growing. Back in 2010, Kentucky had just over 833,000 residents age 60 and older. By 2024, that number had climbed to more than 1.12 million, which is about a 35% increase over those 14 years. This population shift has important implications for public health and systems. This means more individuals are living with chronic conditions, functional limitations, and increased risk for injury. At the same time, older adults often value independence and autonomy and may want to remain in their homes and communities for as long as possible. So as this population grows, the need for injury prevention, safe environments, and supportive services becomes even more important. This slide gives us a broad look at major injury categories affecting older adults in Kentucky. What you'll notice right away is that falls stand out across every level of severity: emergency department visits, hospitalizations, and deaths. Fall rates were so high, I could not include them in the non-fatal graphs, but I made note of them in the highlighted boxes at the top. Falls aren't the only concern, though. We also see meaningful rates for motor vehicle injuries, poisonings, firearm injuries, and self-harm or suicide. These patterns remind us that older adults experience a wide range of injuries, not just falls. Another thing to keep in mind is that some of these categories, like suffocation or assault, have lower rates but still represent serious events when they do occur. And when we look at self-harm and suicide, even though the numbers are smaller compared to falls, the impact is significant. These graphs help us understand why we spend so much time on falls, but also why we need to pay attention to other injuries as well. As the dominant injury cause among the 60-plus population, we're going to look closely at fall-related injury trends. Between 2018 and 2004, we saw 1,938 fall-related deaths among adults 60 and older. That means falls made up about a quarter of all injury-related deaths in this age group. So even though we often think of falls as something minor or inevitable, they can have serious consequences. Over these 7 years, fall-related injuries accounted for more than 80% of all injury-related hospital stays for older adults, and in the emergency department, falls made up more than 61% of all injury-related ED visits. This graph shows how fall-related death rates have changed over the 7-year period. Fall-related death rates show an overall upward trend from 2008 to 2004, with a noticeable dip in 2020, which is likely due to the COVID-19 shutdown. That was followed by a steady increase that peaks around 2022 to 2023. Compared to the 2018-2019 baseline, recent years remain elevated, indicating a sustained increase in fall severity and mortality. This graph breaks down fall-related death rates by sex. Across all 7 years, men had higher fall-related death rates than women. Women also saw increases over time, but their rates stayed lower. There are a few reasons for this gap. Men often have higher rates of chronic conditions that affect balance and mobility, and they may be less likely to use mobility aids or participate in fall prevention programs. Men also tend to have more serious injuries when they do fall, which increases the likelihood of a fatal outcome. This slide breaks down fall-related death rates by age group. Adults aged 60 to 69 had the lowest fall-related death rates. For adults 70 to 79, the rates were about 3 times higher than the 60 to 69 group throughout the 7-year period. The most striking pattern is in adults 80 and older. Their fall-related death rates are dramatically higher than the younger groups. In 2024, it was 17 times higher than the youngest group. These differences don't mean that falls are inevitable as people age, but they do show how the consequences of a fall become more serious as you age. This graph shows how fall-related death rates differed by marital status. We see that widowed adults had the highest fall-related death rates, married adults had the next highest, and divorced adults had the lowest rates overall. These patterns likely reflected a mix of factors. Widowed adults are more likely to be older, to live alone, and to have fewer supports in place, all of which could increase both fall risk and the severity of the fall. Divorced adults tend to be younger within the 60 to 69 population, which may have contributed to their lower rates. Now we are moving on to fall-related inpatient hospitalizations. This graph shows the overall hospitalization rates for fall-related injuries. The hospitalization rates were relatively stable from 2018 through 2023, with a slight decline around 2020, followed by an increase in 2024. Compared to pre-pandemic levels, 2024 suggests a potential upward shift after a period of stability. More than half of the fall-related hospitalizations were due to falls that occurred on the same level, such as slipping and tripping. 5.6% of these falls were falls on or from stairs, and another 5.6 were falls from bed or a chair. And almost half of the fall-related hospitalizations resulted in a fractured hip. This graph shows that women consistently had higher inpatient fall-related hospitalization rates than men. Throughout the 7-year period, women had around double the rate compared to men. This graph shows how fall-related hospitalization rates differed by age group. These rates are very similar to the death rates we previously saw. Therefore, fall-related hospitalization rates also increased with age, with the 80-plus group having rates around 8 times higher than the 60 to 69 age group. Again, this trend reinforces that fall prevention efforts needed to be especially strong for adults in their 80s and beyond. This graph shows how fall-related ED visits have changed over the 7-year period, in which we can see an upward trend. Following the COVID-19 pandemic, during this time, there was an average increase of 369 fall-related ED visits per 100,000 people per year. Almost half of all the fall-related ED visits were due to falls that occurred on the same level. 6.6% of these falls were from a bed or a chair, and 5.2% of these falls were on or from stairs. Much like the inpatient hospitalization graph, we can see that women had consistently higher rates of fall-related ED visits. These differences in ED visit trends could be due to the fact that women are more likely to seek medical care after a fall, while men were more likely to delay care or avoid the ED unless the injury was more severe. This graph shows the trends in rates for fall-related ED visits by age group. Much like the death and inpatient hospitalization trends, the rates for fall-related ED visits increase with age. In summary, falls are the leading cause of both fatal and non-fatal injuries among older adults in Kentucky. We see increases over time in deaths, hospitalizations, and ED visits. Adults aged 80 and older have the highest rates across all outcomes. Women experience higher non-fatal injury rates, while men have slightly higher death rates. Widowed individuals have the highest fall-related death rates, and nearly half of fall-related hospitalizations involve hip fractures. Overall, falls represent a major and growing public health concern in this population. Here I have listed the populations most at risk for falls. Adults 80 and older, fall rates and severity increase significantly with age. Adults with mobility limitations such as arthritis, neuropathy, and difficulty walking. adults with multiple medications, especially those that may cause dizziness or drowsiness. Vision problems also play a factor. Similarly, balance and strength issues can make it harder to recover from a trip or prevent a fall once balance is lost. Adults living in homes with environmental hazards such as poor lighting, loose rugs, clutter, and stairs. Adults who have fallen in the past year, and we also see higher risk among older adults who live alone or who have limited support. Falls may be the most common injury among older adults, but they are also one of the easiest types of injuries to prevent. And here are some ways to reduce that risk. One important strategy is making home safety changes, such as removing loose rugs and clutter, improving lighting, and installing handrails on stairs. Another key area is strength and balance exercise. This could include physical therapy or other exercise programs designed for older adults. Regular vision and hearing checks are another important prevention strategy. Also consider supportive footwear and mobility aids. Shoes with good support and non-slip soles are important, and when needed, canes and walkers can provide stability. Also, community programs really matter. Kentucky has several resources that support fall prevention. And lastly, a social connection. Reduced isolation can lower fall risk. Falls are clearly the leading injury, the only one. This next section shifts our focus to other important injuries among Kentucky residents aged 60 and older. This graph looks specifically at motor vehicle related deaths among older adults from 2018 through 2024. Overall, the death rate remains somewhat stable over time. I did not provide graphs for sex and age differences for these types of injuries, but I did make a small note about their trends. First, men had more than double the motor vehicle death rate compared to women. Second, adults aged 80 and older had nearly double the motor vehicle death rate of adults aged 60 to 69. These graphs look at non-fatal motor vehicle injury outcomes. For inpatient hospitalizations, overall motor vehicle injury rates were decreasing, then rose again post-pandemic. Men had a higher inpatient hospitalization rate than women. We also see that hospitalization rates increase with age, which is consistent with what we saw for deaths. For ED visits, the overall rate has increased steadily since 2020. Women had slightly more motor vehicle related ED visits than men, about 15 to 20% higher. And adults aged 60 to 69 had the highest ED visit rate. That pattern may reflect differences in driving exposure. Adults in their 60s are often still driving more frequently. Reducing motor vehicle injury risk. The first strategy is to support safe driving skills. Programs like AARP Smart Driver and AAA Roadwise can help older adults refresh their driving knowledge. Another important step is to reduce high-risk driving situations. For some older adults, it may be safer to avoid driving at night in heavy rain, during rush hour, or in unfamiliar places. Improving vehicle safety is also important. Newer vehicles may include features that can help compensate for slower reaction times or reduced vision. We should also expand transportation alternatives. Community transportation, senior transportation programs, rideshare options, and family support can help older adults stay connected without putting themselves at unnecessary risk. And finally, we should support safe driving transitions. Giving up or reducing driving can be an emotionally difficult thing for older adults because it is tied so closely to independence. So a gradual, supportive transition can help people maintain dignity, mobility, and quality of life while prioritizing their safety. This slide shifts to drug and non-drug poisoning related deaths. Among Kentucky older adults, overall, the death rate steadily increased, then dipped back down in 2024. Men had more than double the poisoning related death rate compared to women. Death rates also decreased with age, with the highest rates among adults to 69. That age pattern is different from what we saw with falls and motor vehicle deaths. In this case, the younger segment of the older adult population appears to be experiencing the greatest burden of fatal poisoning. These graphs look at the non-fatal side of poisoning injuries. For inpatient hospitalizations, overall, the poisoning rate steadily increased since 2021. Women had higher rates than men, and hospitalization rates also decreased with age, which mirrors the age pattern we saw for poisoning deaths. Overall, ED rates were variable over time. The ED rates were fairly similar between men and women, and again, rates decreased with age. These findings suggest that poisoning risk may be particularly relevant among adults in their 60s and early 70s who may still be living independently, managing multiple prescriptions, and navigating chronic conditions without always having close support or medication oversight. Reducing drug and non-drug poisoning risk. These injuries can result from very everyday situations, but there are ways to reduce the risks. As with all other injuries, it's important to review your medications regularly. Improve safe medication use at home. Tools like pill organizers, medication charts, and written routines can help reduce confusion and support correct daily use. Another major goal is to prevent accidental overdose. That means following dosing instructions exactly. It is also important to store medication safely. Medication should be kept in their original containers and away from other chemicals. It is also important to remember risks like carbon monoxide exposure. Carbon monoxide detectors are an important safety measure, especially in homes with gas appliances or attached garages. Finally, we need to improve health literacy and support. Clear communication, caregiver involvement, and simple written instructions can make a real difference. This next section focuses on mental and behavioral health, which is a critical part of injury prevention for older adults. Why mental health matters for older adults. First, mental health affects injury risk, recovery, and independence. Someone who is depressed, isolated, cognitively overwhelmed, or struggling with anxiety may be less physically active, less engaged in healthcare, and less able to manage medications or daily safety needs. Secondly, mental health conditions are prevalent among older adults. These conditions may be longstanding or they may emerge later in life. Also, factors like social isolation, chronic illness, and medication use can all contribute to mental health challenges. And finally, addressing mental health improves more than emotional well-being. It can also improve quality of life, safety, and overall functioning. So in many ways, supporting mental health is also an injury prevention strategy. This slide focuses specifically on suicide and self-harm injury rates among older adults. Suicide rates among older adults remained relatively stable from 2018 to 2024, with a slight increase following 2020. Overall, there is no strong upward or downward trend, but rates remain consistently high. Non-fatal inpatient self-harm injury rates declined from 2018 through 2021, followed by a slight increase in recent years. One of the most important findings here is the strong differences by sex. Men had a higher suicide rate that was 7.3 times higher than women. At the same time, women had a slightly higher non-fatal self-harm inpatient hospitalization rate. We also see differences by age. Adults 80 and older had a higher suicide rate than the younger groups, but they had a lower rate of non-fatal self-harm inpatient hospitalizations. This pattern may suggest that self-harm occurs among the oldest adults, so warning signs and opportunities for intervention may be missed among this population. This slide shows the count of emergency department mental and behavioral diagnoses among adults aged 60 and older from 2018 to 2024. These categories are not mutually exclusive, so one visit could involve more than one diagnosis. The largest categories were anxiety disorders and depressive disorders, with anxiety disorders representing the highest count. These are not isolated issues affecting only a small group of older adults. They are common and they show up in ED settings in substantial numbers. So this is important because untreated mental health conditions can affect medication adherence, physical activity, sleep, social engagement, and healthcare use. One key protective factor is to stay socially connected. Social isolation is a major risk factor for depression, worsening health, and suicide risk in older adults. Again, it is always important to review medications because some medications can affect mood, sleep, confusion, or anxiety. Manage chronic conditions effectively because chronic pain, disability, and serious illness can affect emotional well-being. Another prevention strategy is encouraging routine and purpose. Daily structure, meaningful activities, hobbies, and social roles can all help protect mental health and support a sense of belonging. Knowing the warning signs is also important. This may include withdrawal, hopelessness, or sudden changes in behavior. And finally, we need to seek support early. The earlier that depression, anxiety, suicide ideation, or emotional distress are recognized, the more opportunity there is to connect someone to treatment and support before a crisis occurs. This slide highlights some important resources available in Kentucky. The first is the 988 Suicide and Crisis Lifeline, which connects people to crisis support. Individuals can call or text 988, and support is also available through their online chat. Kentucky also has 14 regional community mental health centers, which provide treatment and support services across the state. These centers are an important entry point for care, especially for people who may need ongoing mental health services. The Kentucky Department for Behavioral Health offers additional programs and statewide resources, and the area agencies on aging and independent living can help connect older adults to support services that address both mental health and daily living needs. And finally, NAMI Kentucky provides support groups and education, which can be especially valuable for both older adults and family members. So to close, I want to emphasize a few major takeaways from this presentation. First, Kentucky's older adult population is growing rapidly, and that means the need for prevention support and aging-related services will continue to grow with the population. Second, falls, motor vehicle injuries, poisonings, and self-harm all contribute meaningfully to ED visits, inpatient hospitalizations, and deaths among older adults. Falls remain the dominant issue, but they are not the only one. Third is that injury patterns differ by age, sex, and mechanisms, which tells us that prevention cannot be one size fits all. Adults in their 80s face different risks than adults in their 60s. Men and women also experience different injury patterns, and those differences matter when designing interventions. Fourth, mental and behavioral health are essential components of safety and well-being. Injury prevention is not only physical, it also includes emotional health, social connection, and access to care. And finally, Kentucky has evidence-based programs and community resources that can reduce risk and improve quality of life. Are visible, accessible, and used early enough to make a difference. Overall, the message I hope you take away is that older adults are a vulnerable population, but many of these injuries are preventable. With the right support, we can help older Kentuckians remain safer, healthier, and more independent. And then here's my contact information. And if anyone wants to look at the specific data specific to their region or looking at different demographics, please reach out and we can look further into that.
Thank you.